Good morning. I'm Cindy Hall, President of the Women's Congressional Policy Institute. Welcome to this morning's discussion, the second in our briefing series, Childbirth Should Not Be a Death Sentence, Global Maternal Health and the Impact of COVID-19. We have held a number of briefings on maternal health over the past 2 decades. It is particularly important now to discuss both best practices and challenges to improving maternal health and how the pandemic has impacted on-the-ground efforts to reduce maternal deaths. Our special thanks to the Bill and Melinda Gates Foundation for their support for this series. The Women's Congressional Policy Institute, or WCPI, as most of you know, is a nonpartisan, nonprofit public policy organization whose mission is to bring together a community of bipartisan women policymakers and trusted partners to advance issues of importance to women, develop the next generation of women leaders, and foster a more effective and representative democracy. We work closely with the members and staff of the Bipartisan Congressional Caucus for Women's Issues. I would like to thank our congressional briefing co-sponsors, the leadership of the Women's Caucus. Congresswoman Brenda Lawrence and Debbie Lesko, co-chairs, and Congresswomen Madeleine Dean and Jennifer Gonzalez-Colon, vice chairs. Our thanks to our speakers today, Ms. Claudine Mensah Awute, Dr. Rita Hashimi, and Dr. Kogi Agarwal, and the CARE and Chapago teams. I would like to acknowledge Congresswoman Madeleine Dean, Women's Caucus Vice Chair, Congresswomen Susan Davis, Lois Frankel, and Lucille Roybal-Allard, and former Congresswoman Marjorie Margolis, who are joining us today. Each has made maternal health a priority in their work. As noted in the invitation for today's discussion, only questions that were submitted in advance will be asked due to time constraints. We will be live tweeting during the briefing. We encourage you and others to do so as well using the hashtag WCPI Global Health. I am now pleased to introduce Congresswoman Brenda Lawrence, co-chair of the Congressional Caucus for Women's Issues. Congresswoman Lawrence is serving her 3rd term representing the 14th District of Michigan. She serves on the Appropriations and Oversight and Reform committees and has been a strong advocate for women's health, reducing maternal mortality, and closing the health disparities gap for women of color.
Good morning, and thank you so much to Cindy Hall and Cheryl Williams from the Women's Congressional Policy Institute for organizing this event and bringing attention to COVID-19 and the impact on maternal health. Worldwide, there are over 35 million cases of COVID-19 and over 1 million people have died from contracting the disease. As the pandemic progresses, the situation worsens in low and middle income countries. Early on, entire countries had lockdown, economic downturns, and the public fear associated with contracting the virus has put the security of millions of mothers and their children at risk. The pandemic has caused discrepancies in mental health services. Families are foregoing pre- and postnatal care because of fears of contracting the virus. Back in March, when we were bearing the brunt of this pandemic and learning so much about it, I had a letter with the co-chairs of the Bipartisan Women's Caucus and the Democratic Women's Caucus to request that the priorities we provide priorities for health, and that doctors with the guidance on what is the impact that COVID has on pregnant women and what is the impact on women particularly. When women are afraid to give birth at the hospital for fear of infections, the the virus becomes then a real issue on mortality of childbirth. In international community, we have made a bit of progress with placing the health and the well-being of mothers at the top of our priorities and reducing the overall numbers of death. We have, when we look at the COVID-19, it requires us to look through a different lens and to really to be sure that we, in the capacity that we're in Congress and in the organization like the Women's Policy Institute, that we're speaking up and looking after women and during this COVID. I want to thank you all very much. We look forward to hearing your recommendations and seeing how we can move stronger to protecting and providing care for the women in this country. I want everyone here to know that this pandemic is now being called a she-demic, because the impact that this virus has had on women, when it comes to majority of our frontliners or essential workers are women. We're talking about our children going back to school, that's predominantly women. When we talk about our caregivers, our nurses, our cashiers, it's women. And so the impact of this pandemic has been extremely heavy on the shoulders of women. And then you talk about childcare in addition to that. So we have a responsibility, and I'm so glad that we're having this opportunity to have this discussion. I look forward to hearing from you, and hope to see you all soon. Be safe.
Thank you so much, Congresswoman Lawrence, for your remarks and your leadership on so many women's issues, both domestic and global. I am now very pleased to introduce our moderator for this morning's discussion, Dr. Koki Agarwal. Dr. Agarwal is Vice President of DC Operations for JPIGO. She's an internationally recognized expert in safe motherhood, reproductive health, and family planning policies and programs, with more than 25 years of service delivery experience. For over 2 decades, she has led, managed, and implemented large-scale USAID-funded global health projects. Currently, Dr. Agarwal directs the 5-year Momentum Country and Global Leadership Project within the USAID-funded Momentum Suite of Awards. She previously directed the predecessor USAID flagship Maternal, Newborn, and Child Health programs, including the Maternal and Child Survival Program from 2014 to 2019, and the Maternal and Child Health Integrated Program from 2008 to 2014. Dr. Agarwal.
Thank you so much, Cindy, for your kind introduction, and thank you to Congresswoman Lawrence for your remarks and your commitment to safeguarding maternal health in the midst of the pandemic. In the 3 decades that I've worked to ensure high quality, equitable healthcare for women and their children across the globe, this fact holds true. The health of a mother affects the health of the entire family and the community. The world is at risk of losing millions of women and children due to reductions in coverage of essential health services that are required during this COVID-19, reversing the hard-earned progress towards sustainable development goals to date and posing catastrophic consequences for households and communities. Because of the pandemic, countries now face the enormous task of ensuring that women and their children continue to access the care they need to survive labor, birth, and the first 24 hours following birth, which is the most critical time when we lose women and newborns. As women around the world navigate the changes that are brought on by COVID-19, it is really important to remember that 4 essential interventions for healthy pregnancy and birth remain the same throughout the world: antenatal care, delivering with a skilled attendant who has access to emergency services if needed, breastfeeding, and postnatal care. Today, we will hear from 2 extraordinary maternal health champions who are working tirelessly to address the challenges resulting from COVID-19 in Nigeria and in Afghanistan. They're applying innovative and evolving solutions every day to ensure that women and children can still access the care they need, including receiving essential care during the pregnancy period, safely and giving birth in health facilities, accessing voluntary family planning services and space pregnancy. I'm really pleased to now introduce our first speaker, Claudine Lenza Almute. She's the Regional Director for West Africa for CARE. Claudine serves as the Regional Director for CARE's USA's West Africa region and also operates on their international programs and their senior management team. She has served with CARE in a number of senior positions in many countries, including Togo, Ghana, Rwanda, Mali, Benin, and Nigeria for over 20 years. And most recently, she has taken on this role of the country director in Nigeria, where she is leading processes and new ways to include innovative models of presence and partnerships to multiply the impact and increase the Southern voice. She has an unwavering passion for gender equality and women's empowerment. Let's hear from her.
Thank you very much, Dr. Koki. And I first want to thank the Women's Congressional Policy Institute and the Congressional Women's Caucuses for this opportunity that is given to us, CARE and GPIGO, to talk today about maternal health and the impact of the COVID. As Congresswoman Lawrence said, the COVID affects much more women. And I'm going to start telling you the story of a pregnant woman named, let's call her Aisha, that I met with in the past, who has been through a situation in Sierra Leone. Aisha is currently pregnant. 2 months ago, she went to a health facility, the nearest to her village, but she couldn't have access even to the health personnel, not talking about the healthcare. Nurses didn't even ask her what she was suffering of. Instead, they refused to let her in or to treat her and asked her to return home and self-isolate for 2 weeks because of the COVID. Aisha went back home, anxious as you can imagine, and she had no other choice than going to traditional health attendant with all risks related to it. As we know, Africa is the continent that is the less affected by the COVID. It is not only a health crisis, especially in West Africa. That said, it has aggravated the existing critical situation and challenges that women face in terms of access to maternal health services and support. Women, as we know, in sub-Saharan Africa suffer from the highest maternal mortality ratio in the world. And they represent 68% of all maternal deaths in the world, while the population is 15% of the world population. And in countries like Sierra Leone, women are the most affected. Today, only today, as we speak, a woman will die and 20 others will suffer from serious injuries, infections, and disabilities as a result of delivery. Childbirth should not be a death sentence. If that is the case, so why are so many women paying the highest price to give birth? There are pre-existing conditions and risk factors and challenges that women face, and as I said, that are aggravated by the COVID crisis. On one hand, we have delay in decision-making in our society, especially in contexts like Northeast Nigeria. Women have to get the permission of the husband or the male in the household to have access to health care. Traveling to the health centers or health facilities is also a challenge, and having access to quality service is another challenge they face. As for Aisha, there are thousands of women who are denied access because of the COVID and because of simply being women. And during this COVID, this is made more complex because of the interpretation of government restrictions related to physical distancing and isolation. CARE, from the beginning of the COVID, conducted rapid gender analysis in the 11 countries we work in West Africa. What we have learned from it, and I will talk about the situation in Nigeria, is that it is more and more difficult for women to get life-saving maternal health care. Why? Because of lockdowns, curfews, and transport bans that prevented them, in addition to pre-existing social and cultural challenge to access. We also see that there is a widespread stigma and fear of COVID infection from health centers, knowing that health staff are the ones who have been the most affected by it. And then there are also financial and human concerns. As we know, in West Africa, many countries like Mali, Niger, and Nigeria were already facing a security crisis, with, for the case in Nigeria, more than 1,700,000 internally displaced people, of which more than 55% are women. And all this population, and women especially, they have seen the access to maternal health reduced because of diversion of resources to respond to the COVID, and also a challenge that I mentioned earlier. Again, in Nigeria, when we conducted our rapid gender analysis, we use phones, we use WhatsApp, etc., to collect information. A woman told us that maternal health services, such as pre and post natal care, family planning, and attended delivery services have become so difficult for them. And in addition to that, they have also to face the need to choose between investing resources they have in feeding their family or going to the hospital when they have access to that. I mentioned earlier myths, rumors, and misinterpretation and misperception. And this in West Africa, when you know our history of Ebola, you understand that it makes it difficult. In countries like Sierra Leone, where people were known to get there when they are infected, women don't want to get there because they don't want, once they come back, to be seen as people who are bringing back the COVID to their family. So when you look at all these factors, you just wonder how women can manage to safely give birth in such situations. I don't want to name gender-based violence that they face because of restrictions, being physical violence, rape, etc. I don't want to name here increased child marriage, knowing that in West Africa, we have 4 out of 10 women or girls who marry before the age of 18 and who are exposed to a higher risk of mortality because they deliver in the first year of their marriage. They are not yet 18, and then they have their children at the age of 15 or 16. Because they have too many children, all these are factors that they are facing. That said, it is incredible to see how vibrant, how dynamic women are in West Africa. CARE has been working with women who form savings groups and who are now very vocal and participate in decision making. When the crisis started, these women used their savings money to buy like soap, etc., to help peer women, to buy hand washing stations, soap, etc., personal protective equipment to help them. They even supported health facilities. And this has contributed to them being at the table of decision making. As a result, in some communities, they manage to get decision makers to ensure that they don't divert resources from maternal health support. We have also worked in countries where CARE works in the region to distribute delivery kits to lobby government at all levels, local, district, and national level, and also provide health workers and communities with information, support for them in the way in welcoming pregnant women, assisting them and supporting them. There are many activities that I can list here that have helped us. Together with women's group, we've also succeeded in using, I mentioned it earlier, mobile phone, WhatsApp, to share information across the platform. They reach out to millions of women in West Africa to inform them of how safe it is when you use the protection mechanism to get to the hospital for pregnant women, to health centers, to have access to care and support. And I am, to finish these introductory words, I am so proud to see how these women have managed to stop or reduce, prevent child marriage in this COVID time, to address myths and rumors and misperception, to address underlying factors of high mortality for women in child delivery. They do that because they believe that for them, impossible doesn't exist. And they are open to work together with all of us who are on this platform today to address the causes of high mortality of women, especially in this COVID time. Thank you very much.
Thank you so much, Claudine, for those powerful remarks and sharing the stories from Nigeria and the power of women to collectively work and do things for themselves under adverse circumstances, such as what is happening in the country level. So now it's my great pleasure to introduce our second speaker, Dr. Rita Hashimi. She is an Afghan medical doctor with 10 years of experience in clinical family planning, maternal, newborn, and child health, service delivery, and health system strengthening. In her current role as the clinical support team leader at a USAID-funded Hemorrhage project, she provides technical leadership support and supervision to family planning, maternal, newborn, and child health activities across 5 urban areas in Afghanistan. As a skilled trainer, she has extensive experience in building the capacity of Afghan healthcare providers, including assessing the clinical needs and developing and overseeing a mentorship process. She oversaw the implementation of mentorship strategies in 53 public and private health facilities that targeted more than 1,500 providers. She received her medical degree from Afghan Medical University and speaks fluent Dari, Pashto, and English. Over to you, Dr. Rita, and I know that you're going to keep your video off because of bandwidth issues. Thank you.
Yeah, thank you so much, Cookie, and respected women members of the Congress and Congressional staff. Good morning from Kabul, Afghanistan. I'm here today to thank you for your sustained commitment to women's rights and health. In the last 20 years, millions of Afghan girls have avoided childhood diseases, gone back to school, continued their education to become doctors, nurses, and midwives, and reclaimed the dignity and respect that they deserved. As a mother of a young girl, I see a future where she would be respected, heard, and be given an opportunity to contribute equally to the prosperity of Afghanistan. And it makes me hopeful. This has been possible because of our partnership with the international development community. And now is the time to ask everyone to continue this partnership because we need it now more than ever. We have a lot to be proud. Maternal deaths have become almost 1/3 of what they were 20 years back. We now have more than 20,000 midwives who can provide professional care. Just last year, 500,000 women received essential care during pregnancy period, gave birth, at health facility and brought their children to get immunized. A similar number of women used contraceptive to space their birth. In one of the hospitals we support, a 28-year-old woman came with severe headache and nausea in her 9th month of pregnancy. Because of available loading dose of magnesium sulfate and competent staff, she could be treated on time and gave birth to a healthy baby. Just 2 years prior, her previous pregnancy resulted in a stillbirth. Our joint action saved lives. In the past 6 months, COVID-19 has brought additional pain and suffering to the lives of women in Afghanistan, who have been already experiencing conflict for almost 35 years. In the April-June quarter, utilization of prenatal and delivery services declined by half from the previous quarter, and also from the same time period last year. Communities have stayed away from hospitals in fear of getting infected. Women's mobility has been further restricted, limiting access to family planning and essential prenatal and postpartum services. A current United Nations projection states that maternal and newborn death will increase significantly because of increased barriers to essential maternal, newborn, and family planning services. And even during the pandemic, health facilities were attacked by insurgents. Female essential health workers were affected disproportionately. They had to ensure care at primary health facilities, protect themselves without the required PPEs or lab facilities. Similar to many other countries, these women were also a primary caregiver for sick family members. Furthermore, they had to take care of their children because the schools were closed. In Herat Regional Hospital in the West, in June, 1/3 of the service providers that we work with, all female, were infected with COVID. And the hospital struggled to maintain essential maternity services. The two largest causes of maternal death in Afghanistan are mostly preventable, which are postpartum hemorrhage and eclampsia. Postpartum hemorrhage, or excessive bleeding after birth, can be prevented and managed if a woman gives birth with skilled staff who has access to life-saving supplies. Eclampsia caused by high blood pressure during pregnancy can also be prevented and managed through quality prenatal services in the 3rd trimester, as well as during and after birth. In the low-resource setting like Afghanistan, family planning is a critical intervention, as pregnancies delayed will also protect a woman from dying from pregnancy-related complications and improve child survival. We know the solutions, but we need to raise women's and communities' awareness of when to seek care, strengthen referral system, and ensure quality, respectful care closer to home. COVID-19 has devastated our primary care infrastructure, and its effects will be felt for a long time. JPIGO, as a champion of maternal and newborn health, has taken several steps to ensure that the essential healthcare workers are supported. When it wasn't possible to meet face-to-face, we used mobile phones and apps like WhatsApp and Viber to follow up and support the providers. We jointly with Ministry of Public Health developed protocols to triage and treat women suspected with COVID who came for pregnancy-related services. We have worked hard to ensure that care and commodities remained available closer to home. But we can only do so much by ourselves, and now we need your support. We have had a long journey in the past 20 years, showing resilience in the face of many challenges. We have improved women's health and education, but COVID-19 threatens to roll back our gains. We need your support to ensure that our girls are educated and have a role in rebuilding the society after this pandemic, and in the longer term, addressing many gender-related barriers. I leave my family every morning to go to work, earn a living, and serve my community. Many women in Afghanistan currently do not have this choice because of uncertainty around COVID-19, as well as other daily challenges. To ensure that childbirth is not a death sentence, a lot of work is needed in the coming decade in Afghanistan to reduce maternal mortality. We must also ensure all healthcare workers are protected and work in an enabling, secure, and safe environment. I am hopeful that together we can make this a reality. Thank you so much.
Thank you so much, Rita. This is amazing, discussion on what has happened in Afghanistan and how some of the challenges have led to things that can be improved further. So let's dive into our discussion with both the speakers today. And I will start off by asking a general question to both of them that speaks to what changes, and you alluded to this in your remarks, both of you, but I was wondering if you could speak a little further about what changes you saw that the fear of contracting COVID-19 has had on the number of pregnant women seeking care, healthcare during this time in your country or region. So maybe starting with Claudine first.
Thank you, Koki. What we have seen in countries where we work, being in Northeast Nigeria or other countries in West Africa, is that the fear of COVID displays at two levels. One is at the level of pregnant women themselves accessing to health facilities. The other one is from health service providers to welcome them and open up to treat them. And then another aspect of it that displays also with the fear is the availability of products to help to like treatment, medicines, etc. When you put this all together, we don't have data today to talk about or to show the impact on the access to health facilities for delivery or pre or antenatal care for pregnant women, but this is significant. When I take an example of a health facility where we work in northeast Nigeria, where we provide maternal health service and support, the number has decreased by almost 1/3 in the peak of the pandemic. This is what I can say, but again, I don't want to make it general to the context where we work. It can be lower depending on the context where we operate. Over.
Thank you. Rita, would you like to add something? These are excellent points, Claudine.
Thanks, Cookie. Yeah, yes, from the, I think from the data point of view, there is also uncertainty regarding the pregnant women affected data in Afghanistan as well. But comparing to other world, we had less number of, because with the health facilities that we were working, we received less number of women with the suspected or positive COVID cases. But the fear of COVID, which is like a fact that everywhere, that was a challenge for women and also for especially for pregnant women too, and the fear of getting infected for the COVID, that was a challenge here in our communities as well.
Yeah, very real issues, I think, because women are not only are much more vulnerable during their pregnancy to additional infections. So there's appropriate fear at their end. But Claudine, you also raised a very important point of the challenges that the healthcare provider face in terms of being able to provide care under circumstances where they don't have proper prevention equipment, personal protection equipment, as well as proper IPC, infection prevention practices at their facilities. So I think those are both combining, adding to the challenges that we face. But I think we are also hearing that these challenges have forced countries and health systems to look at things a little bit differently and put in different measures to provide access to healthcare in these challenging circumstances for pregnant women. And maybe you could provide an example or two from your country where you work, that what unexpected innovations have happened as a result. And I think, Claudine, you spoke a little bit about what's using WhatsApp and using, the savings group, but what other innovations you think have happened that we want to share with the world and that should become something that we look at more seriously going forward?
Thank you for the question, Kofi. Actually, innovations that we've seen during this COVID crisis build on existing mechanisms that were there. When I take the example of a country like Benin, where CARE worked with partners and health districts to develop mobile phone access to information and first access to pregnant women. CARE works to train village facilitators, community health volunteers to use mobile phone and collect information and forward them to health facilities so that women can have easily access and they can be taken in charge when they reach out to these communities, these centers. With the COVID, what we have observed is that these community volunteers on their own decided to reach out to more communities than they did in the past. And they used that opportunity to add information that they would share on WhatsApp about how COVID can be prevented and measures that women can take, and also inform them on, give like statistics that they can share with them. I mentioned women using WhatsApp platform. What is absolutely fantastic with that is women's groups, savings groups we work with in West Africa, they have formed networks and federations What we see now is like one woman sending a message to 25 women, who each of them at their turn will send to other 35 women, and then you will see the exponential spread of the information. So the innovation is not only about the use of the technology, but how working together as a network and a federation helps take the information very far. The last thing, point I wanted also to raise is the way that women who work with, some of them quickly organize themselves, identify women with like sewing capacities, and ask them to produce personal protective equipment that they donated to health facilities, donated to pregnant women, and they made also part of pregnancy kits themselves. So these are some innovations that we have seen, and we continue to build on for the future in terms of partnering with women, supporting them, building on these capacities, and also this inner strength they have to take the lead in the response. Thank you.
Excellent ideas, and I'm really excited to see that women saving women, you know, they come up with ideas that are really important for the community and for the families that are in these difficult times. Rita, do you have anything to add to these examples from Afghanistan?
Yes, Cookie, as also Claudine said, during this pandemic, what worked well for our healthcare workers that we were supporting face-to-face and being physically present in the health facilities. So during this pandemic, we used the platforms for like WhatsApp groups for each hospitals with the designated staff that we worked with them, and also we delivered them the standard messages for awareness, and also to manage their clients with there was fear regarding the breastfeeding of the newborn with the affected or suspected mothers and other issues. So we supported them as an actual in their field to support and to deliver them messages, and also that how they could be better served, especially for the tools which was developed by JPIGO with the Ministry of Health for triage during this time period with the webinars, and also with these platforms. We oriented these all healthcare workers that how they could save lives, and also for the that how they could separate and apply the IPC measures for these facilities. And also for the healthcare workers in the communities, they continue to visiting the pregnant women and in that time for delivering them and also messages that how they could be take care of their self and their families, and also for the pregnant ladies that how they could be protected because they're most vulnerable for the COVID disease. Thank you.
Thank you for sharing, and I'm really glad to hear these ideas and experiences, because we our project had also done a webinar sharing country experiences, and we've had 2 of these webinars already, and the examples we hear are very similar from what you are sharing in terms of use of better use of technology and focusing more on women's self-care and being able to make services available at different points or closer to home during these challenging times. But nevertheless, I think providing services for maternal health has been a challenge in many of our countries, and this could have been exacerbated by COVID-19, definitely. But what do you feel are some of the biggest challenges facing implementation of maternal health programs in your country or region, and specifically in terms of trying to reach more of the underserved or hard to reach populations?
Thank you, Koki. The challenges to reach out to underserved populations are various. What we see most commonly in our region, especially in places like Northeast Nigeria, where we are in the midst of a security crisis, and is the protection issue, protection challenge for women and unfortunately young girls pregnant in being camps or living in communities. Another aspect of it is also the security of health facility staff. As you probably know, in Northeast Nigeria, because of the destruction of more than half of health facilities in the Northeast, health staff, health attendants had to leave places where people are in the most need of their support. So it creates a huge gap in terms of challenge to them. And then some population, as I said, we have more than 1.7 million of internally displaced people. They've moved to bigger towns where capacity to accommodate that and provide support is also a challenge. Another challenge we faced recently, especially with the COVID crisis, is the shortage in supplies because of the lockdown and also generally access to these supplies. Care and partners, we work with health facilities, especially centers, maternal health centers, to ensure that there is no, that there is limited shortage. But that said, there is, we cannot ensure the total coverage of the needs. We work in partnership with local government, state level government, but they also feel, they also face the challenge of bringing the supplies with the COVID crisis. But I want to emphasize that it is the situation we see has been aggravated by the crisis. There are pre-existing factors that were there, one of them being the importance of maternal health in policies in resource allocation. The another one is, and Rita mentioned it, is the number of trained staff. We have the example working with communities to identify, especially young women who are trained and go back to their community to help. And we need to lobby for that more, to invest more in developing such capacity. And we also need to have a better system, information management system, to have the information of where the gaps are, where the needs are, and also where the supplies are, where the capacities are, in order to bring them, connect them. So this is what I can share in terms of challenges and also some avenues, ways of addressing them.
So before I go to Rita for sharing, asking her the same question, since you've mentioned some of these challenges, Claudine, I was wondering in a minute or less, what would you say are your main takeaways, and what would you like the policymakers to consider in their work? Like, what would you like to ask of the policymakers today?
Thank you, Koki. Our main ask for policymakers, and for this one, I'm being like the spokesperson of women and girls we serve. Not only because I am part of them, these are my sisters, etc., but because they used to ask us, to tell us. They say, we are the will to work. Help us, facilitate the space with us. We ourselves fight to sit at the table of decision making. Please help amplify our voice. What I will ask our sisters, the policymakers, is to be these amplifiers of voices of women on the field, to ensure that policies that are made, that impact them, take into consideration their specific needs in terms of access to resources, but mostly to recognize them as key players in crisis situations, in emergencies, to build their capacity to respond to the crisis because they are there, the first responders. Another thing is also about resource allocation to ensure, to support policy efforts, to support advocacy efforts to ensure that resources are not diverted from maternal health issues, and that concrete plans are made to develop capacities and provide resources to this health. And another, and the last ask I will make, we appreciate the visits we receive in our part of the world from policymakers, and we will really love to have them as soon as possible once COVID permits to come and see the progress we make, connect with these women, and also share their experience with them. Thank you.
I share in your passion, and thank you for making that plea. And our CEO for Japaigo always used to say that if you don't have a seat at the table, bring your own chair. So all power to women to have a voice in the policy making and decision making going forward. So Rita, going back to you in terms of sharing some of the major challenges, especially Afghanistan, we know is a very diverse geography where it's harder to reach women in different areas. What would you like to say are the main challenges, and then what would be your ask of policymakers? What is the 1 minute ask that you'd want to make today?
Thank you, Cookie, for the challenges in Afghanistan. As you said, that we have a hard geographical and with the climate which is in Afghanistan, and the waste which is very hard to reach for health facilities. So during the COVID, also that was in place, and women were one was the fare, and the second thing was these harsh ways that how they could get to those facilities and get care. So these were a part of the big challenges and also being infected of the healthcare workers in Afghanistan, especially. That was as I said before, one of the example of the hospitals that more than 50% of the staff were infected. So they were very hard to maintain the essential care services for the hospitals, and also that was really a hard, especially for the small facilities where they had just 1 or 2 healthcare workers, and that was also a big challenge for them for continuity of their services. And during this COVID, some smaller facilities even that were closed for some time due to the infection of the healthcare workers. So I think those were the challenges that we really faced during the COVID situation for Afghan women to seek care. And my message for the policymakers are that we should for the work that we had done, we had lots of gains that just in 2 years, we brought lots of changes with the clinical care and quality provision of healthcare with these facilities. So I will I request for institutionalization of these all efforts, which is need more resources and also time for that. So I will request to continue with those gains that we already have, and in the next few years again for after this pandemic, and also the effects of this to be institutionalize those changes and also those gains that we have in the in our system. So this is would be my request for policymakers.
Thank you so much, Rita. This is amazing, and thank you to both both of you for your passion for saving lives, for passion for amplifying women's voices, and passion for what you do at the country level. Kudos to you. So we see today that COVID-19 has the potential to put us back several years on our goal to meet the Sustainable Development Goals, which were very ambitious to begin with. But while we see that services are coming back after initial period of lockdown, there are many examples of how to build back better that was shared today. And this can help improve the resilience and make our health systems more efficient and more equitable. And I'm an eternal optimist. So I would say, let's take a look at what innovations, ideas that we can take up further and see this as an opportunity to reach the hardest to reach and the most vulnerable populations and continue to amplify the voices of women. Thank you. And over to you, Cindy.
Thank you so much, Cookie, for your wrap up and for moderating this wonderful discussion. And thanks also to Claudine and Rita for so educating us on the realities on the ground for you, both the challenges and opportunities for reducing maternal deaths and addressing so many other issues that impact maternal health, and particularly, of course, dealing with the COVID pandemic. You all are so inspiring, and I think there's a lot for us to learn from you, in addition to trying to support our own investment in global health. So thank you so much. This conversation was recorded and should be available for viewing on our website at wcpinst.org later today. And you will all be receiving an email asking you to fill out a survey about today's discussion. And we hope that each of you will take a few minutes to respond. We may make changes in the format for these discussions moving forward and content, so your input is very important to us. Our thanks again to the Bipartisan Women's Caucus leadership, members and staff, and the Bill and Melinda Gates Foundation for their support for this briefing series. Thanks so much to the CARE and JPIGO teams for all of your support for this event. And finally, my thanks to Cheryl Williams, Cynthia Ramos, Julia O'Connor, and Keelan Smith for their work to make this briefing possible. Thank you so much for joining us.